Okay, I think we can get started. So thank you everyone for joining the BERD seminar today. And just as a reminder to everyone, the Zoom session today will be recorded, and all attendees, when you're logging in, will be automatically muted. But towards the end of the talk, you can unmute yourself and ask questions if you want. And you're also welcome to type your questions in the chat window. And just as a reminder that the slides as well as the link to the recording, you will receive them after the talk if you have registered. So without further delay, today we have Dr. Wenke Hwang from Penn State. He's an associate professor of public health sciences, and he specializes in risk methodology, and among other areas are also focused on health systems issues such as care coordination and integrated healthcare systems. Today, he will be talking about electronic health records, data, and challenges. Without further ado, Wenke, take it away.
Thank you, Dr. Dong. Hi, everyone. My name is Wenke Hwang. I want to talk about electronic health records as the real-world data and real-world evidence has grown its popularity, and this has become a very popular issue. We got calls and questions all the time. What can we do with our own electronic health records? What kind of research can we do? Where do we get access to? And so on and so forth. And I just thought that to take this opportunity to talk a little bit about the resources that we have here from a CTSI standpoint. A full disclosure, this is I'm my current funding support list here, and my current roles as a CTSI informatic co-lead and our Penn State PCORI Clinical Research Network informatic lead. I'm directing a Master of Public Health program in College of Medicine, and I teach a graduate course. So none of this, I believe, present any of the conflict of interest in my talk today. So from the CTSI standpoint, that the Penn State has supported three major data models in electronic health research, electronic health records research: TriNetX, OMA, and PCORnet. And so there are plenty of users that are looking at the TriNetX in Penn State, and then OMA as well, especially in State College. And today, I wanted to focus on the PCORnet as a data resources. So the objective today is really to introduce in the three layers of research resources. As many of you know, that the Penn State is part of the clinical research network called PATH. And the PATH as a clinical research network is part of a PCORnet. So there's a three layers of this informatic kind of a structure that are very helpful for you to understand if you wanted to kind of venture into a research using these resources. So we are going to cover what's PCORnet, what do they do, and what is the PATH network, what do they do, and when is our Penn State team, and what do we do? And then hopefully with that information, we can equip and inform the researcher as you study feasibility and as you consider how do we potentially minimizing or avoiding potential biases because we now have better understanding of where the data come from and how they are created. And also, I wanted to talk a little bit about our recent data enhancement at the Penn State. And most importantly, I wanted to focus on data today. There are many methodologies that involve in electronic health research, electronic health record research. And I'm hoping that we can have another day for that conversation. And that would involve the research and methodology and design with BERD colleagues. And finally, I'm hoping that we can have a list of the 10 minutes of the questions and comment. So a little bit about PCORnet history. PICORnet, it's funded by PCORI, and PCORI is funded from the Affordable Care Act in early 2010. And PCORI is a non-government entity that the federal government or the Congress appropriate a large amount of funding to PCORI to conduct comparative clinical effectiveness research that is not part of the NIH. And hoping through this non-government entity, it will provide more of the real-world evidence to help patient and caregiver to make a better decision. And the scope of this PCORI engagement initially was really starting from a non-randomized control trial, but now including randomized control trial and covering a wide range of research. So at the very beginning of this funding, the PCORI's vision, as they put out a statement, and said that we face many important unanswered questions about healthcare, but our current research system is really not able to answer this question quickly and efficiently. So the idea of this PCORI come up with to create a PCORnet is to say, so we need to link patient, clinician, health system, and researcher together and harness our data to foster knowledge to lead to a better care, and we can do that quickly and efficiently. That's the vision. And with that vision, it created PCORnet. PCORnet is really a vision of network of the network. So this network of the network will foster a range of observational and experimental comparative effectiveness research by establishing the clinical data gathered in real time and real world setting. And data will be collected in a standardized, interoperable format. Affectionately, we call it Common Data Model, or CDM. And this data sharing across the network will be accomplished through a variety of the security measures and protocol and so on. So as you can see, the idea here is to look into the real world data and that is collected in during patient care. And so that it represent the actual population that's seeking care, and it is not a randomized control trial that is basically going through a long series of randomizations and patient selection. So the fundamental data in this is that it's coming from the health system. And in that data, one of the mandates is that we don't alter any data. The data will show going through standardization, mapping, so on and so forth. It's a long process, but we will never alter any data right there. So it's a real world data. And for this PCORnet currently, that we have 9 clinical research network. This research network basically our health system or practice-based network. And I can show you a little bit about where this clinical research network are in a minute. But Penn State is part of the research network called PATH Network that headquartered or coordinating center in Pittsburgh. So, and that's why we come into this. If we are going to talk about the PCORI data in Penn State, how you use it, how do you know about it, and to better inform by those data, we wanted to understand PCORnet and PATH Network first before we get to the Penn State. So this entire PCORnet of the 9 network is coordinated by Duke University. So this is where the 9 distribution network are distributed. It is mostly on the East Coast. There are some on the West Coast and Midwest, but as you can see that they are pretty much rests on a population center. So let's talk a little bit about common data model. So one of the PICONET requirement is that all clinical sites are required to adopt PICONET CDM, which is developed by the PICONET community. So right now, the network has about 70 plus health system or sites that are using the same common data model. So I believe last time I heard is that it's probably somewhere in 40 to 45 million patient population, but the number kept changing. So don't quote my words for that. But it's a large number of patient population that are collected through this network. So through this common data model, every site would organize our electronic health records and define the data elements in the same way that every other site and network participant do. So this is important because it's harmonization, it's a standardization, and there's a lot of the data mapping that is going behind the scene so that the data set that you look at Penn State looks very similar to the data set that you look at the Geisinger's or Temple's and other places. And common data make it easier for us to share, to aggregate, to analyze, and for us to conduct a multi-site study. So that's really a very powerful tool as a common data model to support this multiple center research. Researcher can query the data for millions of patients across a different system rather quickly. So the first step that we did is that the common data model is coming from model 1.0 to 2.0 to 3 to 4, and now it's model 6.1. And there are 22 or 23 table. It's a relational table that capture the electronic health records from the health system. So as you can see, that is kind of a relational table that we created that at the Penn State Health here using the Penn State Health data. The number of data fields, as it is now, we have about 460 data field across 22 or 23 table. And one thing to note is that PICONET is a federated network, or sometimes we call it a distributed network. So what that means is that our patient data would actually never leave our institution. They are kept here behind our firewall and can only be accessed internally. Individual patient records are not allowed to follow beyond the firewall, so only we provide the aggregate result to the research partners and to PICONET and so on. Organizations that maintain control of the information use and compliance with applicable laws. So what it does is that as a distributed network, we actually encourage more partners to join this collaboration with lower legal and regulatory barrier. But for those specific studies that need to engage with patient level data, that we will engage a separate data use agreement, separate contracts, and separate data transfer agreement, and so on. But those oftentimes are based on the PICONET or our network study, and then we engage in a more intense but separate kind of a DUA and DTA for that matter. This is basically a map that shows that the PICONET patient population distribution, again, a little bit skewed toward the population center. And what's cool things about the PICONET is that it's a network that created this concept called the front door. And this front door, it's something that is very interesting that that anybody can actually come together to kind of query the system. And for PCORNet common data model, how it works, how it operates, what does it entail, please check on the PCORNet network. It's called pcornet.org. They have a lot of the data, documentation, and resources right there. You may find that very helpful if you're interested in. They're talking about the version now. They're talking about what data domains that we are operating, how the tables are related to each other, the value sets of each tables, and so on and so forth. So again, reach out to pcornet.org. You can see a lot of those information. And again, the PCORNet created this thing is called front door, which is pretty cool. There are 4 steps in this kind of a front door step. Step 1, the requester can submit a question through the front door. And then the coordinating center will review the question and consult with the requester about the next step. And then the coordinating center will coordinate with the request and compile into a data query. And then we'll send a package to each network partner, including us. And then we will respond to the request. So that is a very efficient way of reaching millions of patient population, a very efficient way. Oftentimes, it took about 2 to 3 weeks for all the sites to respond to a very specific research question and query. And of course, that those communications and the feedback will respond back to the coordinating center are all in aggregate. At this point, we do not send the data out on the patient level. That is something that we need to understand. So what happened when the front door will knock? I would just want to give you a little bit idea of how it operates, how does it work? So for example, on February 13, in the morning about 10:12, we received a request and say, hey, this query will identify the following counts of patient age 40 with the following condition between January 1st, 2018 and October 31st, 2023. And they will list out a whole bunch of specification. And oftentimes on this summary statement that's usually 1 to 2 pages, it will come with another couple of dozen pages of the documentations and technical instruction. So, this was sent out through a automatic system called Jira. And then in this case, 30 minutes later, we'll respond to the coordinating center and say, acknowledge, we receive it, and we download the file, we will respond to this. And typically, that we have about 2 to 3 weeks of time to respond to this central query. So that's basically how front door operate. And that's another example here. And this example was coming from the CDC COVID query. So as a PCORNet network, and it's as a PCORNet common data model hosting site at Penn State. We also participate CDC's COVID-19 collaboration. So under that contract, we also receive query that is representing some of the public health emergencies, the question, what is the COVID-19 situation, the RSV, the flu, and so on and so forth. All this kind of a more urgent query that we get to respond to this query. But this query is not from PCORNet Coordinating Center. This is coming from CDC COVID Collaborative. And there's another collaborative called the Recover that we can talk a little bit about, and it's really an NIH funded also on the long COVID kind of a study that using a very similar mechanism that we can respond to their research needs in a very quickly and efficient way. All these are established by the PICONET kind of processes. So this is another example that is looking at a query looking at the COVID risk groups and what about their geographic location and so on. So this is another query that typically we will receive in something like this, so we can understand what they are trying to do. And their evaluation of this, a couple fronts. Number one, we wanted to know how complicated is this query so that we can time and schedule our responses in terms of our technical infrastructure and our manpower. And two, we want to look at to see if this request is going beyond the contractual agreement. So these are something that we keep an eye on that on it all the time. And for example, another query that come in, and it looks like this. This query aims to query patient with opiate prescription as well as non-cancer patient with opiate. So this kind of a query, we typically had about 10 days to 14 days to respond to those things. So another cool thing that PICONET has done is that they recognize that you can create a common data model and walk away, because data keep evolving, health system keep evolving, and health system and their associated medical center oftentimes do research that needs additional clinical data elements or non-clinical data elements. So what PICONET common data model does is that it says they formalize the concept of supplemental common data table. So which means as a local site, we can create our own common data model table, but we don't share those common data model outside until that when they become more mature and the PICONET governance entity, governance body decided that it's mature enough to include it in a common data model. So I think that this gives the site very flexible way of creating our own needs of the clinical data. And there is a very stringent data quality examination out of a PICONET. There are basically two stages. The first stage is that as every time when we submit a data, let it be the data query for specific study, or for every 3 months, we have a data curation that the first stage will kick in. Needs to check whether or not we adhere to their standard, whether or not our record seems aligned and complete, whether or not the data shows some illogical combinations in our data set, or that if our records can persist, can reproduce over time. So the first stage that this kind of a quality check, conformance, completeness, possibilities, and persistence, these are basic data quality check. And at times, it can be quite stringent. It can be quite labor intensive. The second stage of this is for specific study. The data curation for the specific study would examine a certain thing to identify if there's an quality issue that associated with the intent for the research aims. So as a result, the strength and weakness of the data available in PICONET for specific research use are well known. We know where our strengths are and we know where our weaknesses are. So we communicate that with transparency at the outset of every research effort. So this is a very unique features for PICONET data, because we can equip ourselves with a better understanding of our data so that we make informed decision of what can be done, what cannot be done, and what might lead to potential biases. And after every curation, we will produce a report that have multiple table. Typically, our report range from 90 pages to 105 pages. It's a long report that includes introduction, the data check, the result, and whether or not all these results are conform to Picronet's requirement. So this is basically the table that we have to deal with pretty frequently, and this is only the first page of the report that has tables after tables after table that is really working through our data set and tear them apart and try to detect if there's any issues with our data set. And another cool things that we have done over the years is this is called privacy preserving record linkage. So as you know, that linking health system data is almost impossible. However, if we are going to put a multiple site study as a resources for research, that knowing that many of the patients actually across the health system. So some of them are duplicated. And this is not a very huge problem for Central Pennsylvania, but it can be a huge problem for a major population center like New York City, like Chicago, and so on. So we created this kind of called privacy preserving record linkage method. Basically, it's going through data hashing. And if you are interested in this, we can always set another time to talk about this because it's quite involved. And it's basically protecting the health system's data without revealing the patient, but enable a third party to be able to compare your patient to find out, who are the patient overlap across different systems. So for those patients who overlap, you can put their diagnosis data, procedures data together because they belong to the same person. And this data hashing technique went on for a couple of years, and until peak COVID-19 happened. So in COVID-19 happened, that the National Institute of Health formed an N3C group. CDC also formed a COVID-19 group, and Recover, representing the researchers that are looking at the long COVID, they are looking at the same thing. They look at us and say, we have millions and millions and millions of COVID data, but are they the same people? Are they from the same? Community? They're just going from. They're just going to a different health system. So very quickly, the N3C, CDC, and Recover project all urge the sites to engage the data hashing, so that they will be able to use to deduplicate the patient under the public health emergency kind of a law to look at the data in a unduplicated manner. And that just data hashes and privacy preserving methods is coming very handy at that point. So that's a Picronet. So under Picronet, there's this thing called path network. So this path network is that, some years ago, I believe it's in mid 2013 or the third quarter of 2013, that we work with a few partners at UPMC, Pittsburgh, and Johns Hopkins and Temple, and then we come up with this path network that engage and apply for the Picronet network. And so we got funded. It started out with 4 or 5 institutions, and as of today, I think we have 9 institutions in this network. So this is the PATH Clinical Research Network. There's a lot of information in here, and I just checked this. If I click on this PATH network or PATH network for research, that's all the research that they are doing and all the partners that are contributing to this. But if I click on this, I cannot mess up my screen. So I'm going to leave it to you to find out more information and more resources in this link. And then in 2014, as a PATH network, they published an article describing how this network come about and how we organize and fundamental kind of a philosophies and principle informing this in this network. So this is something that if you're interested in, please take a look. So for PATH network, which right now including 9 institutions, but 2 of them were just recently joined. It's a Boston Medical Center and Rush. So I don't believe that their data are included here yet. But for PATH network, as of about maybe a year ago, we have Pittsburgh, Penn State, Temple, Johns Hopkins, Geisinger, Ohio State, University of Michigan, or these 9 institutions form this network with a total of 14 million patient population. And this table is just showing that the distribution of this 14 million patient population and what the electronic health records represent. And of course that all these are, some of those are data date back to as far as 2011. Some of the institutions have their common data model went back as far as before 2010. So if we put together an active patient between 2016 and 2022, we basically have about 10 million patients that across all the network partners. So these are the active patients at the time of the mid 2022. And the total number of patients is about 10 million. And again, it's active patient of their racial distribution across all the different sites. And this table is useful because many of the study, this is oftentimes the question I got asked, is that which site I wish to engage. And the idea is that while we can ask everybody to participate in the study because it's too expensive, but we want to have a more diverse practice pattern. We have a diverse population and community. So this table will come in handy for that kind of a decision. And again, there are 2 new partners here, Rush and Boston Medical Center. We are going to get to know them a little bit better. There's not much I can talk to you right now about them, but we'll get to know them better in the next coming weeks and months. Now, let's come to the Penn State Path to Health team. We have a Penn State team that is led by Dr. Cynthia Hwang, and we affectionately call ourselves Path to Health team. And the data set that we create, we call it a path to health data set. So that it's a little bit kind of a differentiate from the notion of the PICONET data and PATH network data, so that we understand the level of the data set that we were talking about. This is a local Penn State health data. Against that, I'm taking the lead on the informatic. Dr. Damon is also our investigator, our program managers, Chelsea, and we have involved many more project-specific PIs and co-investigator. These are the PI who engage PATH network through our Penn State team. They basically take the lead on those research, and it's a very specific research they have their own team as well. And finally, we need to acknowledge we received tremendous technical support from the EIM team, from the ComIT team. These are a very, very important and valuable team member that supported this system. So a little bit about this Penn State health path to health data. So between 2011 and 2023, we have about 1.5 million patient population. And this is their kind of a demographic distribution. And the gender by the race distribution. And you can use these two tables to really basically talk to your collaborator and say, if we are looking for specific population characteristics, this is something that you can be referenced with. And we have about 7.6 or 8% Hispanic population in this region. We have a very large white population that reflects the central Pennsylvania demographic. But if you look at this Hispanic population that has 7.57% here, and looking at the race distribution, and these are the two tables oftentimes that you can use to answer your collaborator's question that what kind of a communities and patient population are we looking into or are we trying to look at? So one thing I wanted to point out here is that if you look at this and put in the ethnicity and race information together, you'll find that there are about more than half of the Hispanic population that they characterize themselves as other race. So this is a very important notion for the researcher because some of us are interested in the ratios and ethnicity and treat them separately. But in fact, if you're looking at the racial information, many of them are actually characterized as other race. They are in fact Hispanic population. So this is the table that you can come in use and come in handy for you to make those kind of a research decision. The data set also including 22 million encounter that is coming from our electronic health records. Here I highlighted EI and TH is because this AV of the encounter type is ambulatory care, ED is emergency room, EI is basically all the encounter that patient coming through the ED and get admitted to the inpatient services. So these are captured by EI encounter. IP is the inpatient services, observational, and TH is the recent years phenomenon. This is telehealth. As you can see, the encounter data that the telehealth really pick up in the recent 3 years. And if you look at the patient counts by years, each year we have about between 296,000 to almost 473,000 patients in each year that show up at the Penn State Health system. So one thing that you want to consider as you consider the research and the data range that we recommend to look at data beyond 2011, January 1st of 2011, because back in 2010, we don't believe that the data is as good or as complete as what the data show beyond 2011. So this is what we recommend, that if you're interested in using the common data model at Penn State, this is the time and day range that you can consider. This is the encounter type by year. And if you are looking interested in ambulatory care, and you're interested in the telehealth, this is a TH encounter. See that the telehealth encounter really is non-existent until almost 2020. And that is really reflect our COVID-19 responses. And therefore, if you are looking at the ambulatory care visit, of course, that you have to look at the telehealth visits beyond between 20 and 2023. This is something that's for you to consider as well. And also, we are looking into some other kind of information, who pay the bill of those encounter. And the common data model, the payers as well, they indicate in each encounter who pay the bill. And as you can see that there is a self-pay over here. Basically, this is the traditional concept that called it the uninsured or not covered by insurance. So these are the insurance information that the common data model also compiled together. So there are a couple of use examples. I want to run through this quickly. So years ago, Dr. Kwasniewski used this Penn State data and engaged a Penn State engaged a PATH network or multiple site study. So this basically is the algorithm that she put together to query where are the data and what the data look like across different sites. So these are the patient with diabetes. Then what about a patient with pre-diabetes? So these are the definition. So we get to translate this into a algorithm or statistical program, either in SAS or R or SQL, and then we share with our partners for them to compile data. And this is another example of using a high-risk opioid prescribing. So it's the same manner. We will translate this into sometimes pretty complicated algorithms and definition. And this is a study led by Temple that they periodically will send us a package of SAS macro and say, well, this is the data curation for that specific study. When we receive this, we usually have about a week of time to compile another data set for this particular study. And they can come in SAS program, they come in SQL, they come in all kind of a package. So there's something that I wanted to discuss. The reason why we cover from PATH network to PCORNet to the PATH to the Penn State data is that I believe nuances and caveats really matter as you consider the research feasibility, because these are real world data. Data missing is a typical issue and is not missing by random, as many of you are well known. And computer phenotype oftentimes cannot be reproduced in multiple site study. So if you have a computer phenotype works well at Penn State, it may not work well at Geisinger. It may not work well in California or in Florida. So what do we do with it? And also, one computable phenotype, it really works well between 2016 and 19. And then we are going to use a prospective study, and we found that that computable phenotype no longer work. So this over time, these are important kind of a caveats and nuances that for your consideration. And of course, that all these are trying to manage the selection bias. One thing we do want to emphasize is that the interoperable HIT remain incomplete, and therefore regional patient matching across health system is still needed, and we will need something like a patient privacy preserving kind of a mechanism continue to guide us to do this. And as a data user, we should all consider rigorous internal data validation within our own system. we should all consider external data validation against other EHR system, and then we should also consider possible validation against non-EHR data like in claims or disease registry. So here's one example I want to show you quickly. So, and this is the study led by Dr. Abidi. So we are looking at this is 9 different definition of computable phenotype. And the reason this is important is because we want to come up with a study cohort for this particular study, but which computable phenotype really works well. It's of central interest. So what this does is that, hey, why don't we come up with a way to match this particular disease cohort to against that particular disease registry. So you can see how in line with the disease registry with all this computer phenotype. And one thing that we found is that, number one, that if you look at the computer phenotypes, some works better than other, and some method works better earlier on in the health system history than in recent history. So this is the first observation. The second observation is that now let's look at the same method using the EHR run against the disease registry, how the computable phenotype works across different sites. And you can see it draw slightly different conclusion, because as you can see that the health system number 2 here, they have a computer phenotype works really well until recent years. So there are some interesting issues right there. So that's why when we work on this, we always wanted to remind people nuances matter and caveats matter. And we should talk all about those things so that the data are not misleading the result. So in one of the study, we look at, well, if those seekers and patients with higher utilization, are they more likely to be included in all the computable phenotype? So in one of the choices that we make in selecting cohort is that, hey, you know, some of the patients, they only come to the health system once, they never return. So if we include this patient, we may mislead, we may create biases. And other people say, well, wait a minute, if you including those notion called loyalty cohort, maybe your sample will bias toward the heavy user or the sicker patient. So these are the kind of a trade-off that we all have to consider. But this particular exercise looking at high utilization and high cost patient, can we capture their clinical information in terms of diagnosis and procedures? So this particular table showed the diagnosis. In all this, that we go through a few pretty lengthy exercise, and we found that if we combine EHR and Medicare claims for 5 years in our regional health system, multiple system here, and then we compare their high utilizations and their characteristics, how likely that they are going to utilize multiple health systems. And for those people who are using multiple health systems, are they likely for us to miss their clinical information in our EHR? And of course, that our conclusion is that for those high cost, high need individuals, they are more likely to engage in multiple health systems and are more likely to have clinical information scattered across different places. So this is something that we have to really keep in mind. There are a couple of enhancements that we do for our data. I really don't have time to go through that. I want to stop here, and because I wanted to have a question answer. But quickly, that we have enhanced our geographic-based social economic indicators that attached to our common data model. We create a mom and child pair that attach to the common data model so that for pediatrics, for the maternal kind of a researcher, they can study to include both mom and child in the same database. We have worked a lot to capture the intensive care unit, their accommodation. We provide more detail of the provider specialty. And then currently we are working with a few clinical registry here to create the kind of a linkage for both the linking the common data model to the clinical database. So with that, I want to stop here. And any question? I promise I want to leave 10 minutes for your question.
Thank you, Wenke. So there is a comment and a question in the chat box. The comment is regarding the race and the Hispanic table that you showed, where about 50% of other races are Hispanics. Lena has a comment that says Hispanics are an ethnic group who are typically multiracial. The only way to address this inconsistent self-reported data is giving patients an open question to specify their multiracial background. They can be combination of white plus Asian plus African plus Native, or multiple combinations like other ethnic groups. Genomics is the only way to clarify this instead of collecting self-reported data. So that I think is a comment about your cross table, where about 50% of the Hispanic people had marked their race as other.
Yes, and I think that's very insightful. I'm trying to look for the page, but
it's slide 36. Yeah.
Yeah. So yes, you are right. The implication here is this, that as you can see, a lot of the study that they are using the ethnicities and race combination as a basic demographic characteristics. What we wanted to remind here is that many of the Hispanic patient population don't classify themselves in the existing race categories that we provide them. So this led to a very interesting talk, and your question and comment is very insightful, because that basically tell the Census Bureau that your existing racial category, it no longer works well in a very significant way. But thank you for the question.
And then David has a question. He has just tried to request access to PATH through PSU CTSI website and received a notification that we're no longer accepting applications. What will be the process for requesting PATH access in enhancing our research moving forward?
Yeah, and it's unfortunate, because that a while ago we do provide this consultation through the CTSI and to guide the researcher in using the PATH network data, but we quickly get overwhelmed. As you can imagine, that that kind of a time and effort that both Dr. Chang, myself, and our investigator and our program managers are really engaged in a very intense labors and time commitment there that is not sustainable. So we took off the linkage, but we hope that if you have any specific questions or interests, please contact me or Dr. Chang, and we can always talk to you about the potential collaboration, or if you need any guidance or advice or question, that we can work together and discuss separately. So unfortunately, that we can no longer provide this as a consultation that is not sustainable in any way.
Thank you. If there are any questions for Wenke, you can just unmute yourself or type in your question.
This is Stevenson from University Park. Thank you, Dr. Wang. It's very great talk. I just wonder, there's two main networks you introduced, the P-Corny and the PASS. Can you just give a big picture? What's the big difference? For example, is there a big difference in the variable they provided or coverage for these two systems?
Yeah, and thank you for the question. So I know that this can be confusing. That's why this picture is here. So PCORNet is a network of the network. This is a national network system. It has a 9 clinical research network. And PATH is one of the 9 clinical research network that conform the common data model and all the contractual agreement conforms to the network of the network, which is the PCORNet, right? So the highest level is PCORNet, which is nationwide, and then PATH network is really including 9 clinical sites that put together a network, and then Penn State is one of the 9 sites within the PATH network. And all this network in PATH or all the network in PCORNet, we basically all doing the same thing. We create the same common data model, we have the same front door policy, and so on and so forth. Hopefully that answers your question.
Yeah, thank you very much for the clarification. Just one quick follow-up question. So what's the smallest aggregate level you can send out of the firewall? For example, it's possible to get post code level?
No, we typically don't send out data at the patient level, right? So a lot of a query, and it's very difficult for us to show you, the query result because they oftentimes are over 100 pages long. And for those queries, it can be very detailed. And the reason why it's very detailed is because those query result, it is at aggregate level, but it's constructed in a way that the coordinate center at Duke or the PI site, they can put together multiple sites of those results into and reconstruct it into a multivariate analysis. So it is aggregate data. It's not a patient level that we send out, but the receiving side will be able to put them together to answer their research question. That is how this typically done. But there are incidents that we will send out patient level data, and that's based on separate project agreement, based on different IRB and data use agreement. So those are separate.
Okay, thank you very much.
You're welcome. So as you can see, the way that the PCORNet set this network, it's aiming for flexibility. Flexibility in a way that this can be a distributed network. It's kind of like more indirect research and answering in a very aggregated way. But it also can be conducive to a more direct, intimate analysis like using patient level data, as long as you create another user agreement and an IRB approval. So there's multiple way of collaboration. It's all possible under this PCORNet engagement.
We are at 2 p.m., but I guess if there are any quick questions, we can take them. Well, if there are any, if you need to contact Wenke, I think you have, you can contact him through the Penn State email address. Otherwise, thank you, Wenke, very much for the great talk, for introducing all the resources that you guys offer.
Well, thank you all for attending. Bye-bye.
Bye.